And the common considerations that we have to make as to who has what combinations in a practical setting really are based on what we can get our hands on quite often. A common combination at diagnosis would be to use a chemotherapy drug, a steroid, and one of the other agents. So that may well be, say, a cyclophosphamide, a dexamethasone, and a Velcade combination. Has anybody had that combination? Yes? A couple of gentlemen here, yep, and at the back. Or another common one may be cyclophosphamide, thalidomide, and dexamethasone as well. So that uses one out of each of the sort of baskets of drugs. And one of the other themes we're beginning to understand is that using a triplet combination seems to be the way to go, and aiming to get as good a response as we can, and that's measured by a reduction in the number of plasma cells, a reduction in that abnormal protein, and improvement in your general health seems to be what we should be aiming at, certainly each time we treat your disease. We do need to take into account, as your disease comes back, how well whatever you had first has done for you, any particular side effects you may well have been unfortunate enough to have, and that may also impact on which treatment we choose. Some drugs, Velcade is very good for people whose kidneys don't work, so it's a very safe drug to use if your kidneys don't work. Some of the other drugs we may need to dose reduce a little bit. So again, just being aware of the difference and the individualness of your particular disease helps us determine how best to treat it. The balance always is going to be in offering you a cocktail of medication for a period of time that is aiming to get rid of your myeloma, but not tipping you over to the point that life is miserable and you've got so many side effects and you're feeling so unwell from your treatment that you'd rather have your myeloma back, thank you very much. And that is a balance that can be tricky. Sometimes we look at a patient and we make gross assumptions as to how they're going to tolerate the degree of medication we may give them, and sometimes people surprise us. I had a little lady recently who was in her mid-80s, and we gave her quite a whopping dose of steroids, and I phoned her the next few days expecting her to be really causing a lot of trouble at home with her steroids, and it really hadn't affected her in any way. Yet I've had big burly sort of rugby playing kind of young guys who we've given just a sniff of a steroid to, and they really can't cope with it. They're sort of climbing up the walls and very intolerant. So we do need to balance the treatments we're offering, the doses of those treatments, the combinations, with how well you travel with them, and to dose modify and to mix and match, or to perhaps try a different treatment if you're not tolerating it very well. Because if you can't go on living with your myeloma, we're not really achieving much for you, are you? We also need to take into account availability of these drugs and whether they're available reimbursed through the health system, or whether we need to pay for them, and whether that's something we can do, or whether the money's all going to the penguin to remove the sand and the whatever, poor fella. We've heard a lot about that at home in Sydney at the minute, the poor old penguin. This is just an analogy to show you that we need to get the balance right. When I went to Paris for the conference, as well as spending 12 hours a day at the conference learning about myeloma, I actually took some time to go cycling afterwards. And we cycled around the Alsace region, which is a wonderful wine region in France, if anybody's been. If not, you should go. It's a great place to put on your bucket list, definitely. And but we were actually cycling about 100 kilometers a day. And the balance I learned was don't drink the local wine too early in the day, because you're not going to get to your 100 kilometers at the end of it. And that was one day we suffered quite badly, because we met some locals and had a long lunch and had another 50 kilometers to go. But we do need to try and achieve a balance. So just the final couple of slides on treatment before we move into some complications. This is this tumour marker, this protein that we measure to see how much of myeloma you have around and how you're responding to types of treatment. And I've just shown you, this is an example of a patient who has IgA myeloma. There are different types, IgA and IgG being the most common of the families of immunoglobulins that are around. And this is just tracking this lady's myeloma at diagnosis when she has a lot of the protein around, when these red lines are various lines of treatment over a period of time that we have given this lady to get this disease under control, with the line coming down and it being nearest to the bottom is a period of control and stability. And usually the lower the plateau, or the more stable this line is, generally the fitter and healthier the patient feels. Sometimes that doesn't go hand in hand, but usually that's the kind of rhythm of it. So each time the myeloma wakes up, and these are periods of about a year each, so this is quite a long timeline of a year each time. This goes from 2003 up to 2010. So over 7 years, this lady has had 5 lines of treatment and periods of stability in between. That stability may well be on medication. This lady had a period of a year or 2 when she was on thalidomide, but she was able to get on with her life. She was in teaching and managed to go back to work each time, and each time the disease took off, we had different courses of treatment that we applied, and a different course here, and this line came down as well. I haven't mentioned sort of life expectancy of people with myeloma, but I have said that it's incurable, but that people are living longer with the disease. And one of the things that was presented well at IMW was the improvements in survival. People are living longer with myeloma because we have more treatments to manage it. And there has been somewhere in the region of nearly a 50% increase in survival of people with myeloma over the last decade, which is quite phenomenal in terms of improvements in the short term. I mean, 10 years in your lives with living with myeloma is a significant period of time, but in general sort of research in medicine, it's actually quite a short time span. So people are living longer, and patients that I look after, I have a gentleman that's lived he's in his 19th year with myeloma, and that's not without significant problem. He's had other factors, he's been on a lot of treatment, but when he was first diagnosed, he was sort of given a piece of paper that sort of said, you know, I think you might live about 2 years, you might want to sort out your life plans and things like that. He'd just had a baby, so he had his second child, and really thought, you know, managed his life, sold his business and all these things, and is still doing reasonably well 19 years later. So that is an extreme example. I certainly have a lot of people in the 10 and 15 year bracket, but about a decade ago when I started, it was sort of like we might be able to give you 3 years, and now it's 5 to 7, and a large number of people are getting to 10. So in quite a small time frame, things are improving dramatically.
Is it true that 2% of people that are diagnosed with myeloma never go into the treatment stage? They just show it, but they never...
Right, that's a good question. This gentleman was just asking, are there a proportion of people that have maybe a pre-myeloma state that don't need to have treatment? And there is a disorder where your plasma cells are misbehaving a little bit. Has anybody heard of MGUS? Yeah, so MGUS, does anybody know what it stands for? Well done, gentleman at the front. Monoclonal gammopathy of undetermined significance, which is just a great way of saying, yeah, it's not myeloma that needs treatment. It is in the family of plasma cell disorders. Okay, right. So if you had, and I haven't got the slide I usually show people, which is on the left where you may have normal plasma cells, and on the extreme right you have a very aggressive form of myeloma called plasma cell leukemia. Has anybody got plasma cell leukemia in the room? No? That's a sort of aggressive form of myeloma where it usually stays within your bone marrow. It's actually come out of the bone marrow and is whizzing around the blood and behaves a little bit more like a leukemia. Okay. Most people present with multiple myeloma that requires treatment, but there is an abnormality called MGUS, which I think is where the statistic you get is that only, and these people don't need treatment, they just have a little bit of abnormal protein in the blood. It's usually been picked up accidentally. About 3 to 5% of the population over 60 may well have it. We don't need to test for it because they would only move on to have something that requires treatment at a rate of about 1% per year. So if you're diagnosed with an MGUS at about 60, you are far, far more likely to succumb to old age or another illness way before you have problems with multiple myeloma.
So my doctor diagnoses me with myeloma. There's not a 2% of myeloma diagnoses
that don't need treatment.
That's something else.
Well, no, there is. The next phase from MGUS is something called asymptomatic myeloma or smouldering myeloma. And that's probably what you're talking about. And people that have smouldering myeloma or asymptomatic myeloma are certainly going to progress to get multiple myeloma, but they don't have enough of it, and it's not causing a problem, which we would call that they don't have the clinical features of the disease. We call those CRAB features, which stands for calcium, renal, anemia, and bone. That help us determine whether we need to jump in and treat. Most people present with myeloma that needs treating, but you may well have presented with an asymptomatic myeloma where your doctor says, we know you have this, but you might well have it for several years, 2 to 5 years, before we need to jump in which case we will observe you, we will monitor your blood, and if you have any problems, you need to come and see us. And at a time that this myeloma starts to impact your ability to function, clinically, then we will jump in with treatment, because to date there has been no study that says jumping in early with treatment is going to slow down the progression of the disease. There is ongoing studies looking at that, and there are also studies that are looking at, is there somebody with asymptomatic myeloma that has particular features such as cytogenetic abnormalities, these mutations, or other abnormalities that would tell us that this person will progress quicker than another person. You know, again, the individuality. I've had patients with smouldering myeloma who've moved on very, very quickly, and others who are 5 and 6 years and still don't require treatment. I think that's probably what your doctor's been talking about. Yeah. So, and this is actually one of these ladies. So this is a lady who presented with MGUS, which did progress after a period of years. Again, these are 1-year timelines along the bottom. She was picked up with an MGUS, this abnormal protein, but it wasn't causing a problem. She was monitored 3 monthly to 6 monthly over a period of about 3 years. Things then progressed in that she had more plasma cells around and more protein, but she didn't have any clinical features. She was generally healthy. Her blood was not compromised in any way, and she didn't require treatment. And it wasn't until she got to this time, which was 2010, from 2004, that we actually needed to jump in and treat this lady. And you wouldn't know if you met this lady on the street that she had anything wrong with her. She has 3 very big, healthy boys, and is a teacher, and maintained her normal life up until that point. Then we began to treat her, and as you can see, her myeloma parameters dropped remarkably with the cycle of treatment she had, and she's just come through a high-dose therapy and stem cell transplant now. Looking a little shaded, and she's lost her hair, unfortunately, so, but she's back at work now, and the kids have been great at school, saying about her new haircut. Miss, love your haircut, you know, good to have you back. And she's back in the workforce again, and we will continue to monitor her for as and when that myeloma begins to come back again. And that could be a few years. It could be a few months, because we do have people that progress very quickly, but it's likely to be a couple of years before we need to do that again. So, in terms of where treatment is likely to be going, I've just got 2 slides just to show you some of the newer treatments, that some of which don't even have a name yet, but you may well see coming through in the coming years in clinical trials, and to help you understand those. This is, I was lucky enough to go to Rodin's house in Paris. If anybody's been there or not, you should go. And this is obviously Rodin's thinker. And there was a lot of that going on at IMW, I can say. A lot of thinking and a lot of new things coming through. This is what we call in the profession a very busy slide. But what it shows you pictorially, I learned very much from looking at images and pictures and things. And this is actually a myeloma cell living in your bone marrow, and it shows the relationship to bone. So really the take-home message here is this is your myeloma cell here. This is the bone marrow cells here along the bottom, and these are bone cells up here. And all these different lines and markers between these just show the different relationships between your cancer cell, where it lives, and its effect on other parts of your body. And it is a greater understanding of this that is going on in your bone marrow that is providing researchers with new targets to switch off some of these pathways that allows your myeloma cell to live on, and for your myeloma cell to die and you to respond to treatment.